Good morning, everybody, or good afternoon, I think we're at now, just about lunchtime. I am Hazel Cheeseman. I'm Deputy Chief Executive of Action on Smoking and Health, ASH. Just seeing people coming in through into the participants there. Welcome to this webinar on collaboration and smoking cessation services, community pharmacy trusts and the local authority. Really delighted to have some really great speakers today. From pharmacy, from local government, from the NHS. So it should be a really good session. If we move to the next slide, we're really delighted this is a partnership between us and our Smoke-Free NHS network and Helen Pearson's team of pharmacists at the Lancashire Commissioning Support Unit. I'm sure many of you know that the Commissioning Support Unit have been commissioned to support the implementation of tobacco dependency treatment services around pharmacy. And so hopefully this joint event today will give us an opportunity to explore those issues further. So for those of you who don't know who we are, ASH is a public health charity. We were established by the Royal College of Physicians over 50 years ago, and our mission is to end the harms caused by smoking. And in the work that we're doing also with funding from NHS England, supporting the rollout of the tobacco dependency treatment services in the NHS and hoping to achieve as much impact from the rollout of those services as possible. If we move to the next, so it's about supporting the implementation of the tobacco dependency treatment services, of course, but with this particular focus on the follow-up in community pharmacy on discharge from hospital. Which is a really important part of making a success of the tobacco dependency treatment services, but clearly not without its challenges around the country. So we have two objectives for today. First of all, to really raise awareness of the functionality of community pharmacy, smoking cessation support linked to this hospital discharge pathway, and to share our experiences and learning about how we can, get this to work really well and scale it up across more pharmacies around the country. Let's move to the next slide. Brilliant. So why does collaboration and partnership matter? Well, apart from the obvious, it's a core objective of integrated care systems. It's part of their legal duties to support this cross-sector partnership. So it's key to the way in which the NHS is establishing itself in this new integrated care system world, where partnership, collaboration, joining up across geographies, horizontally, vertically, is all really, really important and key to what's trying to be achieved. And it's also a part of, we've got a mixture of organisations on the call today. Some people will be local government, statutory organisations, NHS organisations, but also private organisations, private pharmacies. So let's, thinking about how those commercial interests intersect with the wider objectives of the system around improving health outcomes. And we're also wanting to, the skills in setting up and maintaining partnerships are obviously really crucial. And so sharing more of that today will be really important. Right, let's move on to the next slide, which I think is for me to talk a little bit about me and my pharmacist. So this is Mr. Patel. He is a lovely man who didn't mind being photographed for this webinar, which was very kind of him. And my experience, and I'm sure that all of us on here will have a sense of how community pharmacy is really important to our local communities. For me, Mr. Patel is always there when I have a question. If I have something about me or my children, he's always been there to answer it. But I know from my friends and the people that live locally that he's really, really important and respected member of our community, that people often talk about him. They often talk about the advice that he's provided. And I've been in there and I've witnessed him, treating people who are in there to collect their methadone or in there for other, for the long-term health conditions, treating everybody with respect and embracing them all as part of the community. And the role that community pharmacy plays in our society is really crucial, and it's why smokers often would welcome the idea of receiving more support in community pharmacy. I was talking to Mr. Patel this morning about the support that he's able to provide to his community around things like smoking cessation, and he honestly does find it pretty challenging. He's you know, it's a small business, you know, being able to provide all of those different services for people is quite challenging for him. So hopefully we can explore some of that today as well, about how we can really equip people who are really skilled, really capable and really committed to helping the health of their community, to be able to do that effectively around smoking cessation. So let's move to the next slide. The agenda. Right. So you'll have enough waffling on from me. I'm going to do some polls in a minute and find out a little bit more about you. And then we're going to have an overview of service and progress on the work, seeing how the work's been going with the commissioning support unit. And then we've got a couple of really interesting case studies, one from Wolverhampton, one from Greater Manchester. And then we'll be moving on to having a parallel Q&A discussion. So you can choose which case study you want to go and hear a bit more about, where you've got further questions, go into some slightly smaller groups for those conversations. And then we will come back all together for the last section. So I think now we're moving on for, oh no, we're moving on to the Mentimeter. Thank you, sorry. So for those, hopefully people have tried this before. Olivia's popped the link in the chat, so you can get your phone and you can use this, use a QR code if you've got your phone handy. Pop in the code, or you can do it on your screen. I think go to www.menti.com, put the screen and go that way, and there'll be some questions. So we'll leave it on the screen just another couple of seconds, but also Olivia has popped it into the chat. So
yeah. Claire, do you want to swap over to Mentimeter and show the polls?
Thanks, Olivia.
Yeah, brilliant, thanks.
Here we go. Right, okay, so where are you in the healthcare system? People are already busily answering that question. Thank you very much. So you can see that if you haven't managed to log in yet, the QR code is still there and the code that you need to input in the corner of the screen. So a big chunk of audience here from NHS colleagues in hospitals and local government, welcome. I have to say, it looks like our pharmacy colleagues are slightly underrepresented, so it may be that we need to make sure that we share the recordings of this after the event, and make sure that we're able to share it all with colleagues. So that's very interesting. Thank you for that one. People are still inputting. If you are a pharmacist, please get on the Menti and tell us that you're here. NHS Hospital Maternity, yes, welcome. Monica. Right, Olivia, do you want, I think people can still, if we move on to the next question, can people still complete that? Right, what choice of community smoking cessation services are available in your patch? So you've got a couple of different options there. I don't know if you can tick multiple options. So you've got no community service available, an NHS funded advanced community pharmacy. SCS. Olivia, tell me what the SCS stands for.
Smoking cessation service.
Oh, smoking cessation service. Oh, obviously. And then a local authority funded smoking cessation service, local authority funded community pharmacy smoking cessation services, smokers combination. So presumably that means you've got a variety of those different services available in your area. So people with so what we can see here is that the most common experience is that people have got quite complicated smoking cessation landscape locally, that there's lots of different kinds of services being provided in different settings. And that certainly chimes with the research that we do with local government each year, that we see this kind of complexity in commissioning in the community and in the NHS. Should we move to the next slide, the next poll? I think there's one more. Oh no, there's two. We're only doing two. And then we're going over to our first speaker. Fantastic. Thank you so much for sharing, everyone. It's really interesting to see where people are coming from and to see the sorts of service environment that people are operating in. So I am going to hand over to our first speaker, who is Rob Hebdon. Rob is National Pharmacy Integration Lead at NHS England, and he's going to give us an overview of the new NHS-funded community pharmacy smoking cessation service and the progress of the work so far with the Commissioning Support Unit. Over to you then, Rob. Claire, I think you've got some slides to put up, or Rob will let you know when those slides
just a bit later on.
Thanks, Rob.
Thanks, Hazel. Good afternoon, everyone. It's great to see so many familiar names. Can't see many faces at this time, but great to see the names. But for those who don't know me, I am Rob Hebdon. I'm one of the National Pharmacy Integration Leads at NHS England, and I work on I lead on smoking cessation services within the team. You'll be really reassured to know that I also work quite closely with colleagues in NHS England's prevention and cancer teams, and also with OHED. So just wanted to start things off by offering a bit of background to the nationally commissioned NHS Community Pharmacy Smoking Cessation Service. Now, we love our acronyms in the NHS, and this is no different. This service has helpfully been abbreviated to SCS, and that's how I'll refer to it through the rest of the presentation. Now, for me, SCS represented a bit of a breakthrough for community pharmacy-based tobacco dependency treatment services, because for the first time ever, we had this nationally commissioned, consistent and equitable offer for patients. Until this point, we had the complexity that your Menti poll just described there. We had a myriad of locally commissioned services, all different in terms of who can access, what support could be offered, and what role, if any, the community pharmacy teams would play in that service. So back to SCS, from a policy perspective, the SCS comfortably aligns with the prevention ambitions that have been described within the NHS Long Term Plan. That's where we sit. And it represents a bit of from an evidence base, I guess, it represents an interpretation of the Ottawa model for smoking cessation. Now, I appreciate I'm talking to an informed audience here, but just as a reminder, the Ottawa model is considered by many the gold standard for actions within secondary care. But in a nutshell, kind of demonstrates that the best outcomes are attained when patients are offered consistent, coordinated, seamlessly joined up support with their quit attempt. And this is what we've tried to achieve with SCS, as I'm sure we've tried to achieve with other pathways. So with SCS, a typical patient journey would start with the smoking status being captured on admission, and that they will be visited as soon as possible by a trust-based tobacco dependency advisor. And where support is accepted, this team will support that inpatient through this stay. This is a familiar story to many of you, I'm sure. So as an inpatient then moves, who has accepted support from the tobacco dependency team during the hospital stay, near discharge, they will then be offered the opportunity to continue their quit attempt post-discharge. And if the inpatient then consents to this, then they'll be offered community pharmacy as one of the potential destinations for their continued support. Now, this is the first thing I just want to expand on a little bit with everybody. One of the big learning points from the pilots that preceded the national service. Just wanted to share this with you. Hazel touched on her own perceptions of what a community pharmacy delivers and the role that they have in the community. But what we didn't know at NHS England, we didn't know whether in this particular circumstance, where the hospital, whether it be acute or mental health inpatients, would consider community pharmacy as an appropriate partner for a hospital referral. I'm pleased to say, I probably wouldn't be here speaking to you if it went any other way, but the pilot did demonstrate the patients were more than comfortable with this option. And the reasons for that we captured during the evaluation included things like accessibility of the community pharmacy and existing relationships. So back to the SCS pathway. So once a referral is shared, community pharmacy teams are then able to offer support through consultation, which could either be face-to-face or remote, and importantly, supply of NRT for a step-down quit attempt for up to 12 weeks. So just to reiterate, this is a support and a supply service. And again, I know I'm talking to an informed audience, and we all appreciate how important that is. But just onto the launch of SCS. For many of you, this might be the first time that you're hearing about this, and that wouldn't surprise me because SCS did receive a very intentional soft launch. So currently SCS is only available through acute and mental health trusts, and only when those trusts have a tobacco dependency team in place and able to manage referrals. We have nearly 200, I think it is, acute and mental health trusts across England, and all of those trusts are at very different positions in terms of recruiting to and implementing their part of the service and their part of the pathway. This being the reason behind the intentional soft launch. We simply didn't want the entire community pharmacy network to mobilise, invest in time, training and smokelisers. If there was a risk that they may not receive a referral for it, in some cases must be maybe even greater than 18 months. So this brings me onto where we currently are, where we're currently up to with SCS. Claire, are you okay to just quickly share my slide? Well, I can see that. Hopefully everybody else can. So just to talk through this slide, the graph on the top left shows the number of pharmacies registered to deliver the service as a dark blue line, and the light blue line describes the number of acute trusts that are going live with the pathway. We haven't yet added in mental health trusts to this because as a commission from NHS England to the CSU, we didn't add mental health trusts into their implementation work until much later on in the commission. So yeah, what we've got here is a quick comment on the pharmacy line. You can see that despite the soft launch, there was a huge amount of initial interest from community pharmacy for this service, which is really, really encouraging. And that's leveled off over time, kind of plateaued off now. And we're in a position now where registrations are largely driven by deliberate local engagement directly linked to when the implementation team is confident of a trust going live. So we do see, like last month, we gained another 100 community pharmacy registrations based purely on that kind of activity. The smaller graph just to the bottom left there represents the consultation activity. It was just a very, very easy way for me to demonstrate how activity within the service has kind of taken off. So it obviously there, you can see yourself, it obviously took a little bit of a time for the service to get going, but this is obviously moving in the right direction, in a more positive direction. And as we see more and more trusts going live and more referrals being shared with the pharmacy teams. So the current state of play is that we currently have over 4,000 community pharmacies signed up to say that they're ready to accept referrals for the service. The image on the right-hand side of this slide is taken from the CSU implementation team dashboard, which I'm sure they'd be happy to share the link to, and shows the national distribution of those 4,000 pharmacies. So we currently have these 4,000 pharmacies registered, say that they are ready to accept referrals from the 50 or 60 NHS trusts that are currently live with the pathway. And so far, we are aware of over 600 referrals being made to community pharmacy. And although I have to acknowledge these are small numbers at this time, I'm also really keen to share that where we have community pharmacy teams engaged and trusts reporting in to the dashboard, we're seeing great outcomes in terms of converting referrals into consultations. And then when a patient is successfully recruited and committed to a quit attempt, we are seeing quit rates into the 50%, which I hope you all agree is really, really positive outcomes. Final point from me, all of this wouldn't have been possible without the support of the CSU implementation team and with the engagement and collaboration of those local stakeholders. And I know that my colleagues are going to talk in depth about their experience in the next part of the agenda. So that's my update, Hazel. I'm hoping that's provided a nice segue for you into the next part of the agenda. But thanks everybody for coming and thanks for listening.
Thanks, Rob. Sorry, I couldn't work out how to turn I had to get my myself unmuted. That's a great overview. Thanks so much, Rob. Right, we're moving into our case study section now. So I'm going to invite Olivia Bush, who is the ASH NHS strategic lead, to join us. And Olivia is going to be speaking to colleagues from Wolverhampton. So we have Alina Bauer, for the tobacco dependency lead at the Royal Wolverhampton NHS Trust. And I think Jeff will also be with us, who is the chief officer, Wolverhampton City Local Pharmaceutical Committee. Hi, Jeff and Alina. I'll hand over to Olivia, who's going to have a chat with you both about the experiences in Wolverhampton.
That's great. Thank you so much, Hazel. And yeah, welcome, Alina and Jeff. Great to see you with us. We're going to focus mostly on Alina's account today, but it's good to have Jeff here. We're going to unpack a bit more about Jeff's experience when we move into the breakout rooms later, should you come and join us. This is a trailer for a wonderful breakout room. So Alina, jumping straight in, please could you talk us through a bit about how you set up your service, particularly focusing on the discharge element for the for pharmacy, and how you collaborated closely with other partners in your area, obviously, particularly with Jeff.
Oh, thanks, Olivia. So what we found was useful to do as a trust was to initially engage with our community pharmacies before launching here at the trust. So we did a community pharmacy engagement event in October last year. And this was delivered to community pharmacists in Wolverhampton that had signed up to the advanced service for smoker cessation. And this was done in collaboration with MLCSU and Jeff from LPC. Now, as you know, Wolverhampton no longer has a commissioned local stop smoking service. So within our trust, we had the cardiac rehab specialist nurses who had embedded the smoker cessation offering within patient care support packages. So we therefore felt it was fitting for the trust to trial the tobacco dependency discharge process with this team following the community pharmacy engagement event in October last year.
Yeah.
I then began my role in December and reviewed this piloted work and reviewed the IT system that we use to refer patients to community pharmacy, and noticed that there was inconsistencies with the acknowledgements of the referrals. So I felt it was important to reach out to our patients to see if this was accurate or if it was an error with the system that we were using. And there was variances with their responses. Some had access to support and others had not. So as a trust, we felt it was important to focus on the discharge process before we continued the implementation of the service. So what we did, we began contacting community pharmacies and offered to meet with them face to face with a view to offer additional support. Now, once meeting with the pharmacies, we found that they were in various positions. Some were ready to accept, others had many questions about the pathway, about the systems that we were using. Some were yet to complete training. So there's many issues that were presented within these meetings. But during these meetings, we were able to resolve some of those issues and add additional support and give them guidance and to provide that collaboration between the two of us. And we felt like the meeting of the face-to-face with the pharmacies was highly welcomed, and it led to the formation of effective collaborative relationships. In addition to this, the relationships that we have from Jeff from LPC was extremely important. We as a trust hosted regular meetings, and we had representation from Jeff from LPC. We had Dan from ICB attending, and a representation from MLCSU, as well as us as a trust. And this gave us the forum to present the issues that we were faced with and offer that additional support. And by working closely with LPC, we were able to go through these problems together, identify and bridge geographical gaps. We also thought it was good to provide a newsletter, which Jeff kindly circulates to the community pharmacies with information on our implementation process and the service development. And this is sent out quarterly. So spending time developing these relationships, we developed a master list for us to use when we're live on the ward, so we could map out which pharmacies we could refer our patients to. But adding to that, it's important to note that we have a large amount of our patients that do live out of area. So it was important for us to understand what that local offering was. So created a master list to ascertain the local offerings. And once again, there was differences between those offerings. So we then began that relationship building with our out of area pharmacies, and created a master list for us to link onto when following that discharge process. But it's key that the relationship with LPC, ICB and MLCSU were extremely helpful with working with community pharmacies.
Excellent. Yeah, you've painted a picture of really close collaboration there, as you say, with the LPC, the ICB, all those different stakeholders. That's really helpful. Thank you. So now you've done all this collaborative work, can you just outline kind of what the service looks like now? You know, how many pharmacies you've engaged and so on? That would be really interesting.
Yeah, of course. So just to break down, we currently have 17 pharmacies in Wolverhampton that are accepting referrals. We don't have a locally commissioned stop smoking service, so we are heavily reliant on those pharmacies supporting our patients. And then building on our out of area, we have 17 pharmacies in Walsall, but there's also a local stop smoking service that we can refer to, several in Dudley, but we are building on that.
Right.
They've just launched their service within their area, so we're working together with that. South Staffordshire, we have about 12, but once again, they have a local stop smoking service that we can also refer patients to.
Great. Okay, that's really interesting to see what size you're at, because I can see that there's a lot of intensive work as well that you've needed to put in. So yeah, thanks, Alina. So you were telling, when we had a conversation before this event, you were saying that once you'd done that background work and engaging the pharmacies and working with Jeff at the LPC, you'd set about setting up the hospital team. So I wonder whether you could say a little bit about that, particularly how you've set it up to kind of support that discharge process to community pharmacies.
Yeah, brilliant. So our service consists of tobacco dependency lead, a nurse specialist and 2 advisors. Once we did that background work with the pharmacies, we were then ready to launch the service. But and having early engagement with our ward pharmacy team was extremely important for us as a service. So we completed a presentation and a training session with the pharmacy department within the trust to discuss the service in detail prior to the launch, but also to ensure that there was appropriate NRT supply available.
Yes.
And also that a 2-week supply of NRT was provided to our patients. And we communicate really regularly with our community pharmacy and with our internal trust pharmacy team. So at the end of January, we launched to our piloted ward of cardiology, and we've incrementally rolled that out to other wards in line with our rollout plan. And working with key people such as the ward prescribers has been really helpful for the development.
Great. I might just stop you there because I know that you've collected some data to show kind of how patients are flowing through the system and the number of referrals. So it'd be wonderful if you could unpack that now. I think Claire's going to show a slide to help you go through that. But what was really interesting was, I thought was really interesting, you've engaged the ward pharmacists. Anyway, I'll let you present your data, which is really interesting.
So yeah, just to quickly go through this. So as we've incrementally increased our wards as the months have followed through. So January we had 32 referrals. So we started at the end of January. 11 of which were referred to community pharmacy, and we have a quit rate there at 28 days post-discharge of 53.12%. February, we moved on to 2 other ward areas. So we had 54 referrals, 36 were referred to community pharmacy, of which 51.2% was successfully quit. 79 in March, 35 referred to community pharmacy, and with a 57% quit rate. And then, as you can see, in May, we had 62 referrals that were sent out to community pharmacy. So they're starting to increase incrementally as the months roll on.
Brilliant. Now that's good to see what proportion are going to community pharmacy, and around about that 50% quit rate, although that's for all quits, isn't it? Not just community pharmacy. Brilliant. Thank you. I think we're ready to move on to the next case study, but that was brilliant. Thank you very much, Alina.
So interesting. And I think if people have got more questions, obviously pop your questions into the chat now as well. But we'll be going along to the breakout rooms and you can ask for more detail later. So Olivia is going to now speak to our next case study. So we go over across the way to Greater Manchester, up the country. So we're going to have a look at an example of where referrals can be made to either the local authority smoking cessation services or into the NHS funded community pharmacist service. And we're going to hear, so talking through how that works in practice. So we're going to hear from Alison Scowcroft, who's the community pharmacy clinical lead in the Greater Manchester Greater Manchester Integrated Care Partnership team. Not sure. Andrea Entwistle, senior business and commissioning manager, who is the Public Health Oldham Council, and Sarah Ray, who's a tobacco dependency advisor at the trust, at Oldham Trust. So I'll hand over to you now, Olivia, to talk with our colleagues from Oldham.
Yes, fantastic. Thank you. Just before we start, Sarah, can I just check that you're around as well? Do you want to just pop your camera on? But we'll start with Andrea. So Andrea, it's great to have someone from the local authority. So thank you for joining us. So my understanding is that Oldham was a pilot site for the NHS the NHS funded community pharmacy stop smoking service as before it's actually scaled up to nationwide. So and you and Oldham, before this was launched, you were already thinking about adding a community pharmacy service to funding that yourselves. So I suppose I was just interested in hearing from you. What were the reasons that Oldham had for being keen on commissioning a community pharmacy stop smoking service alongside the other providers? So what do you think the strengths are of that model? Because you already had your own local authority service anyway.
Yeah, thanks, Olivia. So patient choice was our primary reason. We know that different things work for different people, and we've got really high levels of smoker prevalence in our boroughs. So we aim to give smokers as many opportunities to quit as we can. Recognise that it often takes multiple attempts for someone to stop smoking for good. So we wanted to offer this broader menu of options of stop smoking support as part of our wider tobacco control offer as our budget would allow. But why we wanted to include a community pharmacy stop smoking provision specifically, and people have already alluded to a lot of this already, was in relation to the fact that residents often regard community pharmacy as a valuable healthcare service.
Yes,
it's easily accessible. They've got long opening hours. It's delivered within the community, close to where people live and they work. Pharmacy staff are likely to have contact with people that may not attend formal health settings or access to traditional stop smoking or other health improvement services. So these are people that may not have other touch points, and it's that really unique opportunity to be able to engage people and offer that support. Also, the recognition that community pharmacies play that key vital role in delivery of healthcare services, especially as GP and practice nurse time is scarce, and it's a finite resource and there's continuing pressures on capacity. And obviously that pharmacy offer, as Robert already mentioned, has that benefit for people who wanted to stop smoking, who are also moving between your primary, secondary and tertiary healthcare services by providing that consistency and that support from that trusted healthcare professional. So there's lots of reasons for why we wanted to include that community pharmacy stop smoking provision within our range of offers. We had originally intended to commission a community pharmacy stop smoking support offer using a specification that had been collaboratively developed in Greater Manchester using that stop smoking plus model, which has the three levels of support. So, that model that suggests that every smoker is encouraged to make at least one serious quit attempt each year using one of three kind of options. So the first being that self-support for those who want to stop but don't want professional support, that brief support, and the stop smoking medicine for those who want help but not willing to commit to a specialist service. And then we're then looking at that specialist support for smokers who wanted that more intensive stop smoking support. Things didn't progress how we'd originally planned in terms of commissioning that community pharmacy offer, and they haven't done so far, but we were really, really very fortunate to be selected to be a pilot site, smoker station transfer of care. And it's meant that we do now have a number of pharmacies signed up to deliver the advanced service in Oldham, and that there is that enhanced choice of provision for people that are being discharged from secondary care. So with that cohort of people do have that range of options to be able to access their stop smoking support.
Great. That's so. So being a slight devil's advocate here, as a commissioner, what are the pros and cons of that NHS having that NHS commission service in your area? Because obviously you had this idea before of another sort of model, and I think Alison's going to come in here as well to offer her perspective. We're going to have a sort of a little friendly debate.
Absolutely, and obviously worked very close with Alison as part of this. In terms of pros, we've got a very effective discharge pathway. We've got that robust service offer for people coming out of secondary care to continue their quit journeys. And obviously it offers that continuity of care. There have been proven quit rates, and there's been really positive patient feedback. We've got some great case studies where people have tried lots of different ways to stop smoking over the years, and this has been the one thing that's worked for them. And as I've mentioned, we've obviously got that patient choice for that cohort, and it allows them to be able to make an informed decision after having conversations with our tobacco dependency smoking advisors, to be able to choose what will work best for them to be able to have their quit attempt and to stop smoking. in terms of some of the things that maybe are not so much of a benefit, we obviously haven't currently got that equitable patient choice and access. People in community can't access the pharmacy provision currently. I know that Rob's mentioned also that that's, it's part of a phased approach, and, hopeful that there'll be changes in the future, either via NHS or via ourselves. But there is that risk of creating a potentially maybe a two-tier system at the moment. Local authority tobacco control leads don't currently have access to the data from the NHS Advanced Service, but again, I'm aware that that's something that is looking to be resolved. So it is something that hopefully we will be able to access that information, and Alison will be able to provide some more context and information around that. And then also there's the potential that it may be a little bit confusing or difficult or time consuming for community pharmacists to have to bid or deliver two different services for two different commissioners and potentially provide two different lots of information and all of that. It's just that risk that we know that pharmacy staff's time's really valuable, and potentially making it a little bit more complicated than perhaps it could be if it was all by one commissioner.
And I know that one of the other issues that you'd raised was about the funding as well. I didn't know if you'd about to say something about that, because though I don't think it's led to any problems in your area, it's just a potential.
Yeah, there is potential feedback that commissioners may receive from community pharmacies if they're not able to match the same level of funding in terms of payments or in terms of training packages as perhaps the NHS Advanced Service can offer. It's a very generous package that is offered, but that is due to the fact that currently the NHS Advanced Service is to be delivered primarily by pharmacists, and often locally commissioned community pharmacy services can be delivered by pharmacy technicians and other pharmacy staff, so the payments may reflect that.
But I think it has been extended.
Anything else to add on that, though?
Yeah, do chip in, Alison. But I think it's now just been extended, hasn't it, to pharmacy technicians as well, the advanced service, which is good. But yeah, Alison, do come in.
Yeah, that's right. So technicians were included in the delivery of the Nationally Commissioned Service in April or May this year, I think. So one of the big bits of feedback from the pilot actually in Oldham was that one of the pharmacies who was most successful in delivering this service had delivered it through a non-pharmacist route. So we were really quite strong in our advocacy for that delivery of the service to be expanded from outside of the pharmacist alone. And also building on what Andrew was talking about around the amount of work that community pharmacy is delivering at the moment. If we are able to deliver that service by multiple people within the pharmacy, that just helps them to embed the service into their business as usual. So I think pros and cons, Andrew's probably covered most of them, to be honest with you. I think it's great that Oldham smokers can have nationally funded support to quit smoking, which is fantastic. It does complement the locally commissioned service, so the two services run alongside each other. Sarah and her team at the hospital will refer patients into community pharmacy or to the locally commissioned service. I think some of the cons around the service, as Andrea mentioned, is because the community pharmacy service is an advanced service. That means it's optional for pharmacies to opt to deliver the service or not. So quite often where patients' regular pharmacy is not registered to deliver the service, they don't want a referral to community pharmacy because they have a good relationship with their pharmacist. But on the positive side, if their pharmacy is registered to deliver the service, they've already got that existing relationship with the pharmacist, as Hazel talked about with her relationship with Mr. Patel. And actually with a stop smoking conversation, it's really helpful if that existing relationship is in place between the patient and the pharmacist or the pharmacy technician. So that's one of the positives around this service being commissioned at a national level.
Brilliant. Thank you very much, Alison. That's great. So I think I'm just seeing that time's ticking on. So I think we'll move on to Sarah. Could you just give us a couple of minutes from your experience of working in the trust, how you have that conversation with patients about whether they go to because you've got both services, whether they're followed up by the community pharmacist, whether they're followed up by the local authority stop smoking service. A couple of minutes on that would be really interesting to hear. Thank you.
Yeah, sure, Olivia. So yeah, it's basically, it's just about knowing your services that you're providing. So obviously the pharmacy service can differ from the community service. So it's just having a really good understanding of what each service provides. But on top of that as well, it's about, speaking to the patients case by case, and just looking at their history, looking at what they're in hospital for, their previous experiences maybe of accessing a community pharmacy or the locally commissioned service, and just taking everything into account holistically, and to think what's best for this patient, what's the best service for this patient. It may just be something really simple like the patient requires an interpreter, in which case I know that our locally commissioned service has an interpreter service. It may be just as simple as that patient has a really good rapport with their local pharmacy, like Alison has mentioned, and that, they, oh yeah, I'll go down and see him. Yeah, he's really good. Just that nice familiarity with your local pharmacy can just make it, the right choice for that patient. So it's just about, just assessing each case individually, and not really having a tick box exercise as such, but just seeing, what's best for that patient.
There's a judgment there, and you're sort of having that conversation collaboratively with the patient as well.
That's right, yeah. And, and telling them what's on offer, and knowing your service, and then just sort of jointly deciding what's the best option.
Perfect. So this is, joy to my ears. Yeah, it's wonderful. Sounds great. So in our last couple of minutes, I was wondering, Alison, I know that you were involved with the Oldham pilot, which I think reached about 12 pharmacies, and then that grew some more, I think, to about 30, and now you're moving it across the patch. So you're working with about 300 pharmacies. Now, you heard from, which is massive, and I think probably unlike other people doing, but that's just because you're so far ahead, having been involved in the pilot. But obviously, to start with, as Alina was kind of really demonstrating, it's very hands-on, but obviously there's got to be different strategies as you move to scale. So I wondered whether you could just give us a few of your top tips about, perhaps not most people won't be working with such large numbers as 300, but they might be working with 30 or 35, for example.
Yeah, thanks, Olivia. So you're right, with Oldham, we started with 12 pharmacies. We've now got 30 pharmacies providing the service in Oldham. But when we look to ICB level, we've got 10 places within Greater Manchester. So we've got just over 300 pharmacies across Greater Manchester who are now set up to deliver the service. So working at scale has been very important. When we were working at a very small scale, we were quite hands-on in supporting the pharmacies in terms of the referral pathway and helping them with delivering consultations with patients, because we'd gone from pharmacies not being able to deliver any stop smoking services at all to having these 12 pharmacies up and ready to go. So the way that we were engaging with pharmacies obviously needs to change. You can't be very hands-on when you've got kind of 30 pharmacies, and certainly not with 300 pharmacies. So it's looking at different ways of engaging with the pharmacies to make sure that they're aware that this service is being provided. So there was lots of work that we did jointly with the LPC around communications, so email communications out, pages on the LPC website to keep everybody updated as to what was happening with the different trusts across Greater Manchester when they were due to go live. We did a series of webinars jointly with the LPC and with the CSU in the evening to engage the pharmacists, to let them know when their local trusts were going live. We had the Trust Tobacco Dependence teams on those webinars, as well as the CSU and the LPC. So it was a real collaborative effort. And we repeated that message each time a trust went live, just so that everybody across Greater Manchester was aware of what was happening. Lots of email communications, as I mentioned. We also did a little bit of a due diligence exercise for each trust before they were going live for the pharmacies, because, as Rob mentioned at the beginning of the session today, it was a soft launch, so registration opened for the pharmacies back in March 22, but some of our trusts in Greater Manchester didn't go live until the back end of 22 or kind of January, February this year. So a long time had passed between when a pharmacy had registered to deliver the service and when they were actually going to be receiving referrals. So we did quite a bit of work in the meantime to make sure that they were still wanting to deliver the service. They still had trained practitioners in place, because obviously there's some turnover of staff and that sort of thing. So really it's thinking about working at system level has been really beneficial in Greater Manchester for us, and having access to the data that Andrea mentioned. The local authority commissioners unfortunately don't have access to the data at the moment. That is something we're working on as an ICB.
I might stop you there. It's wonderful to hear more, and I think if you want to hear more from Alison, do go into the breakout room, which we will do in a moment after we move to our next item. Thank you very much, Alison, Sarah and Andrea.
Thank you, everybody. Two really interesting case studies, which you can go and find out more about shortly. I'm now going to invite Jaz to join us. Jasdeep, Sidhu, who is a pharmacist in the NHS Midlands and Lancashire Commissioning Support Unit, who's supporting the implementation of the NHS-funded community pharmacy smoking cessation offer in several regions. And so Jaz is going to talk to us about sort of drawing out some of those themes that we've been hearing about, how that applies nationally. And thank you for all the contributions in the chats as well. Lots of really interesting stuff there about the practicalities of working with pharmacy around referrals and NRT and assurance and so forth. And hopefully we can address some of those questions in the breakout rooms and in the chat as well. Handing over to you now, Jaz.
Thank you, Hazel. Hi, everyone. So, like I said, I'm Jaz from the MLCSU. So I've got a few of my colleagues on the call today, and I know a few of them have been answering your questions in the chat. So obviously we help with the facilitation and implementation of the smoking cessation community pharmacy aspect of the pathway within the trust. So really my section here is a very short section in terms of just some of the lessons as a team that we've learned and adapted when we've obviously taken it to different systems, different trusts. We work with various stakeholders. Obviously, we're working with the trusts, we're working with ICBs, we're also working with obviously ASH as well now, and also sort of like public health bodies as well and locally commissioned service. So really, a lot of the stuff has already been echoed, but I think there's no harm in saying some of the stuff that's already been said. But where we sometimes have been working with trusts, some of them have possibly been in quite an early sort of phase in terms of their sort of delivery of the inpatient pathway. Some of the teams might have possibly not been established yet. Their trust tobacco advisors may not have been in place or in training. So some of those trusts were still quite keen to go live and offer that community pharmacy aspect to their patients who had obviously going through a quit attempt as an inpatient. So some of those trusts, we sort of took an out-of-box approach. We did an MDT, a multidisciplinary approach. We, like in Alina's team in Wolverhampton, we led initially when they went live with the service with a cardiac rehab teams. So the cardiac rehab pharmacy team and also the nurses initially were the ones that did the first sort of first 20 referrals when they went live towards the back end of last year. So that was some of the approaches that we took and some of the things that we learned as well, as going as a system. And other aspects were sometimes trusts were probably not in a position to go live across the whole trust, across their whole ward or directorate. So some of the things that we sort of explored was maybe possibly bringing it live on wards or directorates with the highest sort of prescribing of NRT, so getting your biggest bang for buck initially. So, getting those patients discharged with NRT and getting live with that service in there, and then I was able to drive those referrals into the community pharmacy side of things. And I think Alison and what the Greater Manchester team has said about in terms of pharmacies and a lot of these pharmacies, as Rob has alluded to as well, would have probably signed up, and during the intentional soft launch, and a lot of these pharmacies wouldn't have received referrals or had live trust sending referrals for a good 18 months and everything. And I think recognizing as a team, as a CSU, and also communicating that out to the trust tobacco team that some of these pharmacies and contractors are going to need support in terms of their training. They're getting the SOPs in place, having the CO monitors, and just ensuring that the service spec was obviously up to date, and they were in a position not just to be registered to provide the service, but also to be in a position to be service ready and referral ready as well. And I think the LPCs were so important in that as well, getting that comms out and doing those engagement events, getting someone again from the trust tobacco team to be present at these events. So you've got a face and a name and a team behind those referrals as well. So I think that increases that buy-in a lot more from the community pharmacy aspect of things as well. And obviously at the end of the day, we want the pathway to be vibrant. We want those patients to get that same level of support that they've had in the acute trust to be able to do that continuity of care into the community pharmacy aspect of it as well. I think that's it from me, Hazel.
Fantastic. Thank everybody. I hope that was a useful session. We are going to do a couple of closing polls and then send you on your way. So I think, Claire, I need you to share that Mentimeter again. So just a reminder, everybody, you can use the QR code with your phone, or you can go to www.menti.com. Thanks to everybody. Sounds like there were some lively discussions. Look forward to hearing about those. And so you can use the code 23032087. So these polls are going to be about drawing together what we've all learned today. So as you type in, I think all bar the last question that we ask you, the text will appear on the screen. So top tips you'll take away from today, really particularly focused on partnership working and how we can scale up. But anything that you're taking away from today, were really, really great to hear from people. So we've got a couple of communication. I think I'm really struck how important communication is. Actually thinking about the very many number of pharmacies out there we might want to engage with, and given the complexity of their daily lives, how we communicate seems absolutely crucial to me. Yeah, lots of collaborative working. Let's see if I can read this one here. Move my thing out of the way. Getting in, I can't. Oh yeah, can you scroll down the screen a tiny bit there? And we can see what else people are posting. Getting in touch with all the community pharmacies and bettering those relationships pre-launch. Yeah, relationships, discussions, communication, lots and lots of really common themes coming out here. Be interesting to know what sort of digital platforms people are using in due course. I know those referral pathways are really challenging, and those feedback loops are really difficult as well. Olivia's just posting in the chat there for those of you who've not joined the Menti. Fantastic. And patient choice. I mean, I think that's absolutely crucial here, that for some people, community pharmacy is absolutely going to be where they want to go and get their support to stop smoking. And as far as possible, that's something we should seek to support. Brilliant. Thanks for that. People still trickling in with responses. A soft launch. Yeah, interesting. Not trying to go out there with a big bang, trying to resolve some of those teething issues as we start. You can see how I'm ramping up, and it's definitely the lesson from Oldham, starting small and building up and making sure that you can do things like the referral pathway. Great. I wonder as well, Olivia, thinking about the communication and right at the beginning, we didn't seem to have an enormous number of pharmacists and pharmacies in our audience. We might think from our communication point of view about how we communicate this really useful session to them. Okay, should we move on to the next question then, Claire? Thanks so much, everybody, for engaging with this. So what action will you take following today's event, or things that you might do differently? Particularly, really interesting to hear if there's things you might do differently. Oh, that's an interesting word. Whoever wrote that might need to repost. I don't know what that means. Consider a soft launch. I think people posted slightly before you meant to. Yeah, interesting for sure. And that pharmacy building, relationship building with pharmacy. We could build pharmacies. I hear they're more likely to be closing down than opening up at the moment, which is a shame.
One thing that struck me as well was that sometimes as you roll out, particularly with your out of area work, you could engage the pharmacists, but people haven't necessarily linked it up with the local authority, for example. So I think some of it will be about reaching out, especially considering, if we looked at the beginning, so many people have those combination of services available in their areas. So I think, yeah, reaching out to try and work with those other partners will be important.
Yeah, and if we have people on here, local tobacco control leads, people who were coordinating at ICS level, I think it's really interesting to think about how you think about this in the round. What's the quitting pathways in your areas? you know, what does it look and feel like if you're a smoker looking for somewhere to quit and you're going through that inpatient experience or going through that community experience? How do we make sure we can like really maximize the opportunities to provide support in a way that really work for people? Lots of really interesting challenges there.
And I know Andrea had some absolute top tips on that as well, so we didn't get to them this time, but yeah, definitely.
Let's come back to it then for a future. Andrea, you're going to
event
booked again. Pharma outcomes. I'm sure that means something to people. I guess that's the IT platform people can use.
It is, yeah, that's right.
Brilliant. Okay, I think responses have slowed down, so we'll just move to the next one. This is where I think we don't see do we see the responses to this? This is just for us, is it, Olivia?
Yeah, it'd just be useful to know which part of the session you found most helpful. I think you can vote. I can't remember. I think I set up so you can vote for more than one.
Vote for what you found useful.
Yeah.
And tell us as well if there are things that you want us to be doing in the future. Let us know.
We'll come to that in the next one. But yeah.
All right. Thank you.
Yeah, that's the next question. But yes, I think actually for each of these ones, if you just rate how helpful each section was, you can vote for every section.
It looks like people can't vote yet, Claire, in the chat. I don't know if you need to click a button to allow people to vote.
Okay.
Oh, we've closed it.
I think, oh, there we go, it's open now. It should be open.
Okay. Everyone have another go at voting.
You might need to refresh your screen or click through to the next one.
Thanks, Olivia. Is it working for people? There's nods.
Yeah, so we've only got 16 responses, so not refreshing as Nikki's finding. Dave's found it's working again for him, so.
Oh. Well, for those of you that can post, then do. It doesn't seem like it's working for everybody for some reason. No, you had to leave and join, did you, Dave? Oh dear. Okay, we're having some technical problems with this question, which may mean that we just have to ask you after the event what you found useful. Should we move to the next?
We've got 30 responses, so some people are managing it. So
move to the next one then. Our last question, where you can tell us what should we keep, what should we tweak, or whatever rhyme. And please, you can focus that on today's event for sure. Be useful to know. Keep the collaboration, but also thinking about any topics that you want us to cover. Great, yeah, case studies. I'm assuming when people are putting the stuff up that you don't want us to tweak the case studies, you'd like us to keep the case studies, keep best practice sharing. Yeah, great. Hints and tips. Do people want more of the hints and tips? People would like pathway guidance, or they got. You might need to provide a little bit more clarity for us on some of these. People are answering both keeping and tweaking, and it's slightly difficult to know which is which. Keep breakout rooms, reflective practice, excellent. People like that, great, good to know. Case study is really helpful. More workshop time. It's tricky when we have big, very, very large groups as well. So it's good to know that the workshops were working for you, even though we've got quite a large number. We did have quite a large number of people going off to the breakout room. So great that those are valuable. Okay, I will let people continue adding their comments there. Thank you so much today. Thank you to all of the speakers, all of the case studies in particular. It's been fascinating to hear from everybody today.